This episode of AHLA Speaking of Health Law is brought to you by AHLA members and donors like you. For more information, visit AmericanHealthLaw.org.
Well, hello and welcome to the AHLA Speaking of Health Law, where today we are refreshing our deep dive into the One Big Beautiful Act, a sweeping overhaul reshaping Medicaid as we know it. The new law, by the way, has been rebranded by the federal agencies as the Working Families Tax Cut, Public Law 11921. This podcast is an update from our September 5th, 2025 episode. Since our last episode, CMS has published several major guidance documents, including one just late last night. State Medicaid agencies and stakeholders are scrambling to translate these new guidances into operational steps. Passed via the budget reconciliation with razor-thin margins, 51-50 in the Senate, 218 to 214 in the House, this legislation marks the largest Medicaid cut in U.S. history, slashing $911 billion over the next 10 years, and potentially resulting in 10 million people losing health insurance by 2034. From these most recent announcements to dramatic funding changes and rural health innovations, our panel today will break down what matters for providers, stakeholders, and legal counsel. I'm Harsh Parikh, joined once again by Ann Winter and Lloyd Bookman, and together we'll guide you through what's changing, who's impacted, and updates since our last episode, and what the future may hold for Medicaid. Let's first start with introductions. Lloyd, if you want to go ahead and begin.
Sure. I'm Lloyd Bookman. Hello, everybody. I'm a founding partner of Hooper, Lundy and Bookman. I've been practicing as a healthcare lawyer now since 1979. A significant part of my practice deals with the Medicaid program, including specifically provider fees, healthcare-related taxes, as well as state-directed payments.
Great. Ann?
Good morning, everybody. Good to see you guys again. I'm just going to say that.
Yeah, absolutely.
Yeah. My name is Ann Winter. I'm a senior managing director at FTI Consulting. By background, I'm a CPA and got my start as a finance director at a methadone clinic many years ago. And from there, I went to Access, which is Arizona's Medicaid agency, where I was responsible for much of the managed care contracting and all of the capitation rate setting. Since then, I have worked at a couple of health plans, including United Healthcare and Business Development. I was the head of Managed Medicaid Regulatory at CVS Caremark, where I oversaw compliance with 26 different state regulations that impacted PBMs. And I've been consulting for the last 10 years. So happy to be here.
Awesome. And my name is Harsh Parikh. I'm a partner here at Nixon Peabody. My practice really includes representing managed care organizations, healthcare providers, on regulatory issues, as well as stakeholders that are interested in global macro changes in the U.S. healthcare market. So with that, let me first give a quick disclaimer. This podcast is a non-political discussion. It's recorded on December 9th, 2025. All views expressed by myself, Ann, and Lloyd are really our own. They don't represent the views of our law firms or our organizations that we work for. This content is for informational purposes only and does not constitute legal or professional advice. Standard disclaimers apply. With that, let's dive in. Just a quick recap. States, one of the big provisions in the One Big Beautiful Act was what's referred to as the community engagement or work requirements. Specifically, starting in January 2027, expansion population, including adults ages 19 to 64, will need to complete and verify at least 80 hours per month of community engagement, which includes work, education, volunteering, and a mix of things to qualify for coverage and maintain eligibility. States under the law are required to frequently track and confirm these hours before enrolling individuals and doing regular eligibility checks. There are some limited exemptions, including for folks that are disabled, medically frail, children under 14, and states also have the ability to seek exemption or delay implementation from these requirements down the line. Failure to comply with these requirements can lead to disenrollment, although individuals that are disenrolled do have a chance to appeal that decision and take advantage of the administrative review process. The law sets strict federal oversight, reduced funding for noncompliance for states that don't follow these mandates. And CMS and the law expect significant operational upgrades across the US to implement these requirements. To better understand these new requirements, why don't we start in with what we just saw come across our desk last night in form of an informational bulletin from CMS. And if you want to jump in and tell us a little bit about that new guidance from
Yeah,
CMS or historically what we've seen over the last couple of months from
yeah.
CMS.
That informational bulletin provided some guidance, but want to emphasize that there's still going to be more formal interim rulemaking next year. But they listed four key principles. One of them is they want to make sure that the members are being connected to the community, whether it's through work or volunteering. So that is that's principle number one. The second one is state flexibility. And of course, every state wants complete flexibility in the model that we have for Medicaid. However, they want to balance that flexibility with more standardized processes, primarily from a cost reduction. You don't need, I think they're going to try to look to see where they can combine maybe some of the eligibility for some of the smaller states. They want to promote alignment, and you're going to hear this probably quite a bit, but they are going to want to align programs through what is known as APIs and interoperability to collect data. And so that's with SNAP and TANF, the IRS. It could be with ADP, for payroll information. So this is going to be one of the things that Harsh just alluded to is like there's going to be a lot of investments. And then finally, they want to protect the taxpayer. And what that means is all the verification needs to be auditable. They also laid a timeline. The timeline is, as Harsh mentioned, 1/1/27 states must do the verification checks of work requirements and community engagement in that December timeframe. But states can elect up to 3 months look back. So the timeline is if a state elects just that month of December, the information, the verification of community engagement must be provided from the beneficiary in December. However, the state will have to notify the beneficiary in September that they're going to have to provide this information. So there is that notification requirement. Then if you elect two, so you're looking at November and December, that notice goes out in August. So they back it up 1 month. And finally, if you go back 3 months, then you are going to be providing, or the beneficiary will be providing information from October, November, December, and the notification period is in July. So when you think about that, I mean, states are working now very hard. I mean, just even getting these notices written, drafted, getting them out the door, this really is upon us. It's really not a year away. So.
Yeah, I mean, sort of going back in November, CMS confirmed that all 50 states submitted some sort of a preliminary implementation plan for how they will implement this requirement. There were 17 states that requested a good faith delay. We'll see what that means in terms of how CMS executes those requests. But as Ann, you indicated, what we're really anticipating is an interim final rule or some sort of rulemaking from CMS that we anticipate on or before June of 2026. Some other pieces from yesterday's guidance that I just want to pull out and would love your comments. The first is CMS commented on the role of Medicaid managed care plans. So in a lot of states, especially where Lloyd and I are in California, most Medicaid benefits are delivered through managed care organizations at the county level. And what CMS said yesterday was states cannot delegate these compliance determinations to MCOs, while MCOs can assist states in non-determination activities like outreaches, education, or navigation. States directly, the state Medicaid agencies, have to be the ones that make a determination as to whether an individual is qualified and meets these requirements. I thought that was an interesting statement and clarity from CMS. Lloyd, any thoughts on the role of managed care plans or generally these work requirements and how CMS is going about this?
Well, the general notion about work requirements is the devil's going to be in the details. How is CMS going to require states to gather information to ensure the work requirements are met? As we all know, the difficulty with work requirements isn't so much that beneficiaries aren't actually engaged in community engagement. It's that they can't document it. And what I'm waiting to see is what the actual final rules require states to gather in terms of documentation. And that'll determine whether and how many beneficiaries end up losing coverage. As to the role of managed care plans, as you were talking about, Harsh, versus the states, again, it increases the burden on stressed states. Our state has tried to push down a lot of the burden of the Medicaid administration to the managed care plans, get it off their desk. And this guidance is telling us that that can't happen here. The states are going to be in the first chair.
Yeah,
I,
and one of the things that also was in the CMS bulletin yesterday was, and Anne, you hit on this earlier, is that states have to use reliable information first, meaning before asking individuals for paperwork, states must use data they already have, such as payroll, employment records, Medicaid claims or encounter data, higher education, job training, community service data, etc. And only if those data sets aren't sufficient, then could states look to individuals. And anything more on that piece of data sharing? And I know there was a RFI that CMS put out in September, trying to get data about matching standards for verifying work hours.
yeah, and I think this is something, if you look at the legislation, they're appropriating $200 million to states. And I think that $200 million to states is going into modernizing their systems. I think one of the reasons this is ex parte determination, was included in HR1 is because it was a lesson learned from the big redetermination process that every state went through in 2023 and 2024, where some states didn't have the capability to do ex parte, some states elected not to do ex parte. But I think the lesson learned out of the redeterminations was there is a wealth of data out there and you need to go get it. And this is where I did allude to that there was going to be interoperability, where states are going to be required to collect information from all of these data sources. And I think that's where, given the different levels of sophistication for state Medicaid, managed Medicaid information systems, is where states are scrambling right now. And I actually was talking to somebody this morning. A good example of this is Colorado delegates all of its eligibility to its counties. Colorado has 64 counties. Every one of them are doing eligibility in their own way. And, there's some counties with 1,000 people in them. And so one of the things that Governor Polis is looking at, he has a proposal out there, is how do you kind of pull all of that responsibility and parts of it back into a more centralized function? Because not all of those 64 counties are going to be able to potentially modify their systems and their processes and workflows to be able to do everything needed. So this is going to be a state by state decision. And I think one person on the call said they needed an eligibility czar. So we'll see if eligibility czars emerge in the next 6 months while they implement.
Yeah, and we talked about, the last point is, starting date January 2027 for these requirements. In the guidance document yesterday, CMS sort of laid out, what states need to do with respect to its Medicaid population and confirming that these folks starting in January 2027 are eligible. And CMS sort of set out, gave states options. You can do sort of a one check, right? You can sort of review whether that person has information or documentation to support the work requirement contours in December, or you could check twice or provide three different times where the individual would need to confirm prior to the January go live date. Any other sort of thoughts on how you see this playing out? I mean, I feel like states are scrambling to get, essentially building this all together while awaiting more guidance from CMS. And obviously, Lloyd, you talked about, what does this really mean? Is it just a paperwork requirement, or are we sort of actually encouraging folks that wouldn't otherwise be engaging in community activities to do so now?
Yeah, and unless this program is rolled out differently than the couple of programs that have been rolled out previously, I'm afraid it's going to be a paperwork exercise, and we're not going to see significant uptick in Medicaid beneficiaries coming into the workforce or going back to school. Again, the studies so far indicate that
They
folks
didn't.
generally do that now. And so you're not going to, so you're going to, the fear is you're just going to lose people off the Medicaid rolls. Well, it's going to be interesting to see whether states implement these requirements in more stringent ways in states that are less favorable towards Medicaid and in less stringent ways in other states. I'm looking forward to seeing how states themselves react to either try to keep folks enrolled in Medicaid or the opposite.
I think that's a good point. And even as they scramble towards the finish line of 1/1/27, will some say we're just going to, look at that one time because we got to get it done, but then in future years make it, potentially more stringent, during the redetermination process. I've also talked with a few developers. There are companies out there right now that are developing mobile apps for cell phones for Medicaid members, to hopefully eliminate some of that paperwork you're talking about, Lloyd, where maybe that they can download. And so there's a frenzy out there right now in the community to be the one that gets that best product first and be able to sell it into MCOs that could provide it on their already mobile apps. So yeah,
and I think that's right on, right? So, I mean, in a perfect world, we have the seamless data flowing and everybody's sharing with one another, and this doesn't become sort of a paperwork exercise. But as we were prepping for this call, we talked about how there is, a lot of distrust between states and the federal government right now. We talked about, immigration trying to get access to Medicaid data, and concerns that states have there and lawsuits. So does that environment make and what you were describing, technological solutions to seamless, data integration, does that make it more difficult?
I think that could be a state by state basis, but I think that's going to be the individual user may not want to have that information shared for, a variety of reasons that we've seen kind of playing out through immigration enforcement. So yeah, I think so.
Yeah. One point about technology, really poor people don't often have access to technology. They don't have access to broadband internet. They don't have that at home. So if the solutions are going to be internet, even if they're cell phone based, cell phone applications, I don't know if that's going to help the really poor folks who don't have access. It may help others, but it's not a bad idea to add another device but I don't know that that's going to be a panacea.
Well, interestingly, one of the organizations I talked to is going to leverage a federal program that provides free cell phones, and that if somebody doesn't have one, I don't know how big that program is or how wide it can go, but I agree. And hopefully, with all of the rural health technology, grants and initiatives that are going to be coming out, that broadband can expand further.
Right.
Yeah,
Now,
it's like playing whack-a-mole, right? You sort of come
Yeah.
up with a solution, then maybe there's some more problems to it. Go ahead,
Yep.
sorry.
just really quickly regarding the information sharing that Harsh you mentioned, um, the DHS, Department of Homeland Security, has wanted to gain access to Medicaid patient-specific information. A federal court in California said no, issued a TRO against it. DHS, the Department of Homeland Security, has said, well, we fixed the problem that court noted because it was really a procedural problem, and we're going to now seek the information again. We'll see how this plays out. Obviously, a lot of folks are very concerned about that information sharing. DHS wants the data.
Yeah, so a lot of friction in terms of how this can work without causing all of the harms that folks are raising. Let's shift gears and talk about a different aspect of the WFTC legislation. I'm going to keep calling that rather than HR1 or the one big beautiful bill, which is the new requirements on eligibility and coverage. So the new law introduces three key changes for Medicaid expansion adults. First, starting in January 2027, eligibility reviews will shift from once a year to every 6 months, meaning beneficiaries have to renew coverage every 6 months rather than annually. Second, retroactive coverage. So once an individual is enrolled in Medicaid, retroactive coverage is reduced. It used to be 3 months to only a 1 month before enrollment. And finally, and this gets to what we were just talking about, Lloyd, October 1, 2026, immigrant eligibility will be limited for Medicaid beneficiaries to only U.S. citizen, a small group of lawful permanent residents, and certain specific groups, but it does exclude refugees, humanitarian parolees, and others. And so you're going to see a significant reduction in immigrants being eligible for Medicaid. And maybe we jump to you. Has there been any updates on implementation of these requirements? I know they're sort of a little bit farther in the future, but anything you've heard from CMS or state Medicaid agencies with respect to these new mandates?
There are states that already have this in place, again. So I think some states that have already done the every 6 month eligibility for this population are probably feeling this is one thing that they don't have to, have a czar for. But I think, one of the things that I saw here in Arizona, our legislative joint budget committee issued their preliminary view of how WFTC, I have to get used to it, Harsh.
There you go. Yep.
Yeah.
FTC.
WFTC, the
Working
impact,
Families Tax Cut.
yeah, will have on the Arizona budget. And it was really interesting because they went through all of the provisions. It's going to have a big impact on our budget, and it will on every state budget. And that's just going to be an underlying theme on everything here. But Access, the Medicaid agency, requested 290 new eligibility workers to be able to implement the new provisions around community engagement every 6 months. They do it annually now. All of the other things that you talked about, and 10 positions, an additional 10 for IT. But, I think this is, some of this, the administrative burden that states are going to have. It's going to be staffing. And just the costs of it and the IT. I happened to attend last month the National Association of Medicaid Director meeting, and Dan Brillman, the new Medicaid administrator, was there on a panel with some other states. And the three takeaways were it was going to be technology infrastructure, it was going to be staffing, and the third, and what Dan said was, we need partnership with the states because CMS is implementing this their own part of this at the same time. And so, there's multiple implementations going on. They're working with 51 jurisdictions. And so I think the ability to partner with various organizations is going to be paramount into the success of this.
Yeah, and maybe, Lloyd, we can jump to immigration really quickly. California made news a few years ago with Governor Newsom announcing the state was going to accept undocumented immigrants into the Medicaid program. We've seen a bit of a rollback there, but talk about immigrants and the impact of these provisions on that population.
Well, obviously, immigrants are going to be, including lawful immigrants, are going to be losing Medicaid coverage. But what I've been hearing back from providers, particularly hospitals, is the fear factor that folks who are immigrants, including some citizens, are just reluctant to get out in public and are reluctant to go to hospitals. And once they're in a hospital, they're reluctant to provide enrollment information. And so while the patients, once they get to a critical stage, will show up in a hospital ED, then the hospital can't enroll them in Medicaid because the patient won't provide the information. So it's just a large fear factor that is going to discourage people who need care from getting care.
Yeah, and it's not that if you lose insurance, you just don't need health care. You just are likely going to need more acute care that'll be more costly perhaps than if preventative or some other care was provided earlier on. Okay, let's jump. Unless Anne, if you have anything else to add, let's jump to the funding and payment reforms. And Lloyd, this is sort of your expertise has been for many years. As CMS was rolling out its informational bulletins, and lawmakers are really referring to these Medicaid funding mechanisms as abusive financial practices. So let me just ask you an open-ended question. Are these various Medicaid funding mechanism, provider taxes, state director payments, et cetera, are these abusive financial practices? Your thoughts on sort of the way the current administration seems to be viewing these mechanisms that states use.
I think it depends upon whether you're sitting in Congress trying to balance the federal budget, or you're sitting in a state and you're a state governor trying to deal with the state budget and trying to fund the Medicaid program. There's been this tension between the feds and the states for years. I mean, this is the states discovered, hey, we can do these provider-related taxes. We can tax providers, generate the non-federal share of Medicaid payments, and leverage federal funding without having a general fund hit. So this is good. And federal law allowed this. So it wasn't, an unlawful device. It was a mechanism built into the federal law. Congress and various administrations have said, we don't like this because the states really aren't putting skin in the game. They're getting around putting skin in the game. But because so many states, red states and blue states, rely so heavily on provider taxes, the political will has ebbed and flowed on Congress taking action to reduce the availability of provider taxes. My view is we need Medicaid funded appropriately, and frankly, it's not funded appropriately now. Medicaid payments just nationally or lag behind other payments, are generally insufficient to cover provider costs. So my view is, however you get the funding is a good thing, but depends whose budget you're trying to work.
Yeah, that makes sense. And so maybe we can dive in and you can talk a little bit about, the background of what the new legislation does with respect to provider taxes, state director payments, and then we can talk about updates.
Sure. Let me start with provider taxes. HR 1 wanted to cut back on provider taxes, and they did it in a couple of different ways. One, it prohibits new provider taxes, basically, on any new type of items or new type of providers. Can't do that. Any new tax after date of enactment, July 4th, 2025, is not going to be matched by the federal government. And then it imposed new limits for non-expansion states. There are 11 non-expansion states, if I'm remembering correctly. The limit on taxes is the percentage. There's a net revenue percentage limitation on taxes before HR 1 that said you can't have your provider taxes being exceeding 6% of net patient revenue. That was the absolute limit. HR 1 says, okay, for non-expansion states, we're going to say you can't, your limit on the percentage of net patient revenue that a provider tax can be is going to be the percentage of a tax that was enacted and imposed on the date of enactment. So you can't basically increase the percentage of a provider tax on a particular class of items or services. For expansion states, have gone further, and this is endemic throughout HR 1, where they treat expansion states more harshly than they treat non-expansion states. For expansion states, you have the same sort of bottom line threshold. You can't increase the percentage of net patient revenue over a provider tax that has been enacted and imposed as of the date of enactment. But then there's another limit or another set of reductions beginning federal fiscal year 2028. The 6% limit goes down to 5.5% limit, and then by an additional 0.5% each year until you hit 3.5% in 2032. So those two limits, that is, you can't increase the net patient revenue over existing provider taxes. And secondly, even if you do, we're going to reduce the 6% limit down to 3.5% over time. It's going to cost a lot of money. Estimates are well over $100 billion over the 10-year period. So that's a significant reduction. And those provider taxes these days typically support supplemental payments to providers, and that's where the hit's going to be. And given the economic circumstances of many states, I don't see the states backfilling. So something's going to give. There's another requirement called the uniformity requirement that came out of HR 1, which said that basically you can't tax Medicaid utilization at higher rates than non-Medicaid utilization. And a lot of some, this is a big, what the CMS is called a big loophole, because a lot of states have said, okay, we'll have our provider tax programs, but we'll tax Medicaid utilization, say Medicaid days, at a higher rate than non-Medicaid days, which results in easing the pain on providers who don't do a lot of Medicaid. So one of the things in Medicaid programs that the designers try to do is to reduce the number of net losers. That is the number of providers who actually pay more in taxes than they get back in payments. So states have used this device of taxing Medicaid utilization at higher levels than non-Medicaid utilization to try to mitigate the number of and reduce the number of losers. HR 1 says you can't do that. It says basically effective as of date of enactment, you have to have uniformity in your taxing structure. Although recognizing that a lot of states rely on non-uniform taxes, HR 1 said, well, the Secretary of HHS can enact a transition period of up to 3 years. And so we get November 14, 2025, we get some CMS informal guidance in a Dear Colleague letter that deals with both the net percentage of net patient revenue issue and with uniformity, identified as preliminary, with final guidance depending on a final rule. Apparently, their CMS is intending to go through rulemaking. But even though they call it preliminary, this is what they're implementing right now. And if you're in a state that's trying to get a provider tax approved, this is what you're dealing with, even though what if it gets changed later, I'm not quite sure how that impacts you retroactively. On the net patient revenue limit threshold, that is, you can't increase the percentage of net patient revenue that a tax encompasses. It's a tax. The key is that the statute says the threshold is based on a tax enacted and imposed as of the date of enactment. And what CMS did in the November guidance is defined and focused on those terms that said basically enacted means that the state has authorized through its legislative or regulatory mechanisms the specific tax structure. And secondly, that CMS has approved that specific tax structure. So if you had a tax pending as of July 4, 2025 that CMS had not yet approved, that would have increased the size of your tax program. I'm sorry, that increased tax threshold will not be your new threshold. Now, these threshold limits, this threshold limit and the reductions in net patient revenue that I talked about earlier from 6% down to 3.5%, the net patient revenue kick in October 1, the threshold kicks in October 1, 2026. So theoretically, a state can increase the size of its provider tax program now until October 1, 2026, but as of that date, it can't be any higher than the program that was CMS approved as of July 4, 2025, according to this guidance. And that's very controversial, but that's the guidance we have. Uniformity. CMS did establish a phase-in period in this informal guidance. It said for a lot of the uniformity issues have come along with MCO taxes, where Medicaid enrollment taxes are based in some of these tax structures on Medicaid enrollment and an MCO. And if Medicaid and so some of the states have taxed Medicaid enrollment much higher than non-Medicaid enrollment. CMS has said that this is where they view this as a more abusive practice in the MCO arena. So what they've said is that for MCO taxes, beginning at the end, will allow your current tax structure through the end of a state fiscal year ending during calendar year 2026. So if you're a 6/30 fiscal year end state through June 30, 2026, will let you keep your non-uniform structure, if it has been CMS approved, in place until then, but then you fall off the cliff. For other taxes, the date is later because they see less abuse. And no later than October 1, 2028, are you going to have a uniform structure. But that's only if the particular tax structure that you're implementing has been approved, and a lot of the controversy is going to be as to whether a particular tax structure was actually approved by July 4, 2025. I know that's going to be an issue in our state, in California. One of the questions that I've got is what's a state going to do if it disagrees with CMS's interpretation? I mean, CMS sort of holds all the cards here. You either get your program approved and you run forward with it and you get federal financial participation, or you don't and you end up in court and you're in a limbo land for the next 3 or 4 or 5 years. So that's the provider fee side. The state-directed payment side, a little again, a number of reductions. And there's the background of state-directed payments is that federal Medicaid regulations came out in 2016 that said states can indeed direct the managed care plans, the MCOs, how to pay providers within certain limits and under certain guidelines. And pretty much 39 states, I believe, have state-directed payment programs, and there are hundreds of these different programs with different provider groups involving enormous amounts of Medicaid funding. And a lot of these state-directed payment programs, they involve in effect supplemental payments to providers that are in addition to their regular contract rates, and they're funded largely in most states by provider taxes. So there's this close relationship between provider taxes and state-directed payments. Okay, the limit on state-directed payments as of pre-HR 1, as of before July 5, 2025, was the average commercial rate in contracts, which, given the relationship between the average commercial rate and most Medicaid contract rates, was pretty generous, frankly. And states had a lot of room to play with to have their to direct the health plans to pay more to providers to get up closer to the average contract rate. So there's a lot of room there. HR 1 reduces the ceiling on state-directed payments as follows. For non-grandfathered plans, and I'll explain grandfathering in a moment because that's kind of key here. For non-grandfathered plans, effective for rating periods beginning on or after enactment, on or after July 4, 2025, for an expansion state, you get 100%, your cap is 100% of payment at Medicare rates. Now, if you're grandfathered, you get some flexibility. I'll talk about that in a second. For non-expansion states, it's 110%. You get of Medicare, you get an extra 10%. So what's a grandfathered plan? A grandfathered plan is one that was approved, for which a completed, that's either approved or a completed what's called preprint, which is what you submit to get state-directed payments approved by CMS. A completed preprint was submitted on or before July 4, 2025. So if you didn't get your state-directed payment either approved or submitted a completed preprint by July 4, 2025, it's not grandfathered, and you're immediately subject to the 100% or 110% limitation. By the way, our state squeezed in under the gun for the hospital directed payment program. We got it in on July 1st. Somehow or another, somebody knew that July 4 was coming up, and they managed to get a completed preprint in on July 1st. By the way, that's a multi-billion-dollar thing that happened, but by 3 days. So if you are in a grandfathered plan, these you're okay into July 1, 2028. And beginning July 1, 2028, the state-directed payments have to be reduced by 10% annually until you hit Medicare rates. A little uncertain how the Medicare rate ceiling is going to be computed. I suspect it's going to be much like the Medicare upper payment limit, for those of you familiar with that, under fee-for-service Medicaid. It's going to be not on a hospital-by-hospital basis, but on an aggregate basis for all of the class of providers that are subject to the particular directed payment methodology. One other thing that the guidance said, that guidance came out from CMS on September 9, 2025, which was pretty much in line with what I've just said, except it also added a sentence that said you can't increase, basically you can't increase the size of a state-directed payment program beyond the size of the program eligible for grandfathering. So if you have a grandfathered program, what this guidance says is you can't increase the size of the program, um, regardless of its relationship to the Medicare rates. I don't understand that, but that's what they say. I don't understand how that's tethered to the statute, but that's what they say, and that can constrain the growth of many state-directed payment programs. Last, I'll mention, even though this is not actually an HR1 thing, but it's hot off the presses. On Friday, the 11th Circuit Court of Appeal, sitting in Tallahassee, issued a decision dealing with the hold harmless prohibition. Very quickly, a provider tax structure can't hold taxpayers harmless for the provider tax. That's impermissible. If you do that, the feds won't pay matching funds. A lot of states have had over the years the providers voluntarily agreeing to share funding to ameliorate the negative impact on some providers of the provider tax program. So they basically redistribute funds, whether those are Medicaid funds or other funds. They redistribute funds from basically the winners under the program to the losers. CMS hates this. And CMS has taken the position that those informal, voluntary programs among providers are an impermissible hold harmless. Providers take the opposite position and say, wait a minute, if the state's not involved, once we get the money, we can do whatever we want with the money. A court in Texas earlier this year issued a permanent injunction against CMS's interpretation, siding with the providers on the issue. We thought that had national impact because the court said we're setting aside CMS's policy, which implicates nationwide impact. That case is under appeal to the Fifth Circuit. But in the meantime, just Friday, the 11th Circuit said we agree with CMS that these voluntary redistribution programs create an impermissible hold harmless. And if you want to get federal matching funds, you can't have one of these programs. The 11th Circuit, the 11th Circuit case is in a case brought by the state of Florida. The 11th Circuit did not address at all the Texas case, which is curious. So this issue is going to roll forward, and we will see how that plays out over the years.
Yeah, thank you, Lloyd. And really, these financial reforms, I mean, Lloyd, you hit on this, make up the bulk of the savings that the bill is going to provide. Just to give sort of specific numbers, the provider tax reforms and the phase down, that's supposed to lead to 191 billion saved over 10 years. The state directed payment caps and changes there are supposed to lead to $149 billion in savings, for a total of 340 billion from these Medicaid funding mechanisms. So really, where a lot of the funding cuts are coming from are these mechanisms that are used to finance Medicaid. And I don't know if you have anything else to add here on the Arizona front, and what you're seeing in that state.
Yeah, here in Arizona, again, referencing back to the JLBC report, we have a 6% provider tax on hospitals, which funds our Medicaid expansion 10% match. So I think that just one comment, Lloyd, one reason why I think maybe CMS, was giving preference to non-expansion states is they know states are using sometimes these provider taxes to fund their Medicaid expansion, and how that might impact them is they lose some of that. But if you look at our 6%, if we had 6% in 2032, which is when that full phase in down to the 3.5 happens, if you compare that, that's $2.1 billion a year we're going to be losing, and it's big. This is everything that, states are going to grapple with as they, look not only to next year, the fiscal 27 budget, but, as they go on. And also, one of the things that I found interesting in the JLBC report is if a state has uniformity with federal tax rules, that's another decrease because of the way we, tax in our state, with uniformity. And I think that in Arizona in the first year is 453 billion next year because of
Wow.
the reduction in tax. So
But these dollars
Okay.
are just so big. You wonder what's going to happen. States
How do you
don't have a
backfill
big,
that? Yeah. I mean,
yeah,
that's
states
general
don't
fund
have a big
revenue.
pot of,
That's
our
general
state doesn't
fund.
have a big pot of money just sitting out there in
Yeah.
general funds.
Yeah.
yeah, I saw something I think it was in Washington State where there was some lawmaker there proposing to impose essentially put this burden on the tech companies in Seattle that to sort of fill the hole or the gap that's going to be left here. Okay, let's move on. I know we're going to run out of time soon. Let's skip the fraud and abuse provisions. We talked about this on our last podcast, right? These are enhanced provider enrollee verifications that are in the Working Families Tax Cut, duplicate enrollment prevention systems, provider enrollment screening changes. Nothing really much to say about that except CMS has sort of made clear that it's moving forward on those. There's a really great November 18th slide deck from CMS that I think does a good job of outlining and going through these. And obviously, we talked about Lloyd last time, the $35 per service cost share requirement on some Medicaid folks, beneficiaries starting in October 2028. Okay, so let's really get to where I think we've seen probably the most action over the last 3 months, which is the Rural Health Transformation Program. So if you recall, the One Big Beautiful Bill launched this program, setting aside $50 billion over 5 years. The idea was to help rural healthcare providers, not just rural hospitals, but rural healthcare providers generally innovate. The idea would be CMS would distribute 10 billion a year, half equal to all participating states with a plan, and the other half based on states with rural population and hospital needs. States were required to apply by end of this year with a detailed explanation of how they'll use these funds, and CMS was supposed to get back to states on its award decisions. Update us on where this program is, changes, and what you sort of anticipate coming down the pike in the next couple of weeks.
Yeah, CMS put this on the fast track. They issued the Notice of Funding Opportunity, the NOFO, on September 15th. So states, were scrambling, trying to get all their stakeholder feedback on, how they wanted to design their initiatives. On November 5th, states were required to submit their response to the NOFO, and then awards are going to be announced by the end of this month by the 31st, with funding going out right away in January. So this has been really fast tracked. In looking at websites and seeing some summaries of state applications, there's some really big key themes in there, and technology is huge. Back to Lloyd, your point, on broadband is like, how do you get technology out into the rural areas, so you can do telehealth. They're looking at hub and spoke models where you might have, the hub at, a large medical center and then the spokes going out, and that's all going to require a lot of connectivity. So health information technology was number one or number two. The second is workforce development, training, education, on making sure that there are providers out there. And then another big theme was behavioral health and substance use disorder. That was another one that a lot of states are going to be focusing on. So I think the initiatives look really good, really positive. It's just now going to be, executing on how they're executing on them. So, and one thing that is also interesting is if a state, it's kind of like how CHIP funds are done now. Like if a state doesn't spend all its CHIP funds, they're redistributed to other states. And so the rural grant funding, if states don't spend it, it's going to be reallocated to other states.
So Lloyd, this program, doesn't this sort of patch up some of the gaps we'll see as a result of the funding changes and other cuts?
Uh,
Is this, I'm being facetious
it,
here, but is this
Yeah,
sufficient?
it's better than nothing. I mean, from what I hear from rural providers and the numbers I've seen, it doesn't come close to filling in the gap. both the existing gap that rural providers are struggling right now. So it doesn't help with the existing gap. It doesn't help with the extra pressures resulting from HR1. Again, it'll help a bit, but we're going to continue to lose rural health providers, and that's in a community a tragedy. As the rural, if you're a hospital, for example, you're the biggest employer in town. You're the only place, you're the town. Without you, the town could disappear. So these could be tragedies, and states recognize these as super important problems that they have to grapple with. So we'll see. It's again better than not having the 50 billion, but it's not going to be sufficient.
Yeah, I think, please, Ann.
Oh, I was just going to say, there's been a bit of a bleak picture here for me listening to you talk, Lloyd, because we're looking at all the reduction, the over 300 million in payments to providers. And then, one of the questions I had for you is what happens to the workforce? And it's not even a rural issue. It is a statewide issue for everyone, and at the same time, you're losing money there, which could impact workforce. Then you're having all these people that are losing eligibility and go to the hospital for their care. So this looks very tricky.
It looks tricky. Here's a perverse thought. We have a nursing shortage nationally, and I suppose if we lose hospitals, then they'll have their nurses that'll be able to relocate elsewhere. I mean, that's sort of a perverse upside to having a workforce problem. But you're absolutely right. It's a snowballing effect. You lose employer, people lose their jobs, people lose their health coverage, they become uninsured. It is not a pretty picture.
Yeah, so we're definitely going to see lots of distressed healthcare over the next few years. Just to put an end on this piece of conversation, awards, Ann, you said are going to be announced no later than end of this year, is it? December
End of
31?
this year. Yes, December
Okay.
31st.
And then we'll start to see funding flow over the next 4 or 5 years. But to the point, Lloyd, that you made, the cuts we talked about are permanent, while this is a temporary,
Right.
perhaps Band-Aid over what might be a bigger issue. Let's sort of conclude our podcast shortly. What's next? I mean, legal challenges, we haven't really seen many because, frankly, none of these provisions are really ripe to be challenged yet. But I suspect we'll probably see something, right, Lloyd? And a lot of different. We haven't seen obviously the interim final rule or whatever the rulemaking is going to be from CMS, but I suspect there'll be some legal challenges to different provisions here, or are you thinking that
Well,
maybe not so
Florida and
much?
Texas have done it in dealing with the old harmless. I suspect it's possible. The difficulty is the states need to get things approved today and need to have the funds flowing today. And if they're going to take a litigation route, that's going to delay everything. So even if CMS goes beyond, obviously challenging what's in HR1 is going to be extraordinarily difficult. You have to show a constitutional challenge because that's the law. The CMS implementation, maybe we'll see challenges. I'm thinking on the payment and the state directed payment and provider fee side. You may see more challenges to the extent they roll out the workforce requirements and the like in a too harsh a way that's beyond that's arbitrary and capricious, that's beyond what the statute requires. But I'm not so sure I'm going to see the lawsuits on the payment side because CMS, I think, holds the cards here.
Yeah, that makes sense. And there were discussions about rollbacks. I think I heard murmurs about this at the onset of the federal government shutdown, but not really. So there could be future legislation shifts in political leadership. Maybe the 2026 election results that might um, bring forth opportunities to revisit some of these reforms. Thoughts on sort of the change potential legislative changes to what this law is starting to shape up to be?
What we're going to see pain, and it's going to
Yeah.
start hitting around the midterms. Um, I don't know whether that's going to lead to legislative changes before the 2028 election, but it might, because as some of the redder leaning states as opposed to the bluer leaning states are feeling the pain, they'll be putting pressure on their legislative representatives to do something in Congress. So I
Yeah.
suspect we might see some additional funding shaking out to help in certain areas.
I
So
think
be on the
one
lookout for
wild
that.
card is going to be whether or not they extend the enhanced subsidies or what they do if they
Sure.
create HSAs. I think that's going to be, it's not Medicaid related, it's marketplace, but I think the first feeling of pain of what it means that the delivery system is not where it's been for how many years, and people are losing coverage or opting out of coverage, and then the provider community starts feeling that I think those are going to be their initial signals of pain
Sure.
that we'll see that may impact future federal legislation.
Great. And Ann, maybe you can take us home, with all of these financial challenges. Is there a real promise ahead? I think you've, talked about technology. I mean, is that really the potential bright spot, AI as a
I think it
mechanism to,
is. I think it is. I mean, underlying almost everything that we've been talking about and is, going to be the ability to execute, data and data well. And so I think that's where, I think last time I said this is the one big beautiful technology bill. It really is, and if you look at concurrent efforts that CMS is doing, they have a whole initiative on make health technology great again. Dan Brillman, the new Medicaid administrator, came from a technology firm. He created Unitas, which is a platform that can aggregate social determinants of health providers and, provide referrals and close loop, so the Medicaid plan or the state that contracts with Unitas can find out whether or not the member actually got groceries, for example, and so I think there's going to be a big emphasis on that. I think they're going to be a big winner in all of this. But I think this year, everybody's going to be sprinting to 1/1/27, and how we get that, the work requirements, community engagement, and eligibility implemented.
well, great. With that, let's end the podcast. Thanks everybody for joining, and we'll be sure to do an update in a few months again. Thank you.
Thanks, Harsh.
Thanks.